Hello, everyone. I'm Jason Jiang from the Hong Kong University of Science and Technology. I'm very happy to be here to share with you our recent findings on the biomarker development for Alzheimer's disease, which we believe that will provide insights into the development of the diagnostic tools for this devastating disease. So Alzheimer's disease is now an urgent health threat. Due to the rapidly aging population worldwide, the prevalence of Alzheimer's disease has increased dramatically. It is estimated that by 2050, the number of dementia cases, majority of them are Alzheimer's disease, will reach to more than 150 million of the patients. And for those people aged above 85, around 30% of people will suffer from the Alzheimer's disease. The characteristics of this disease include the memory loss and cognitive dysfunctions. It has been shown that the patients will have neuronal loss and brain atrophy. The hallmarks of this disease include the amyloid depositions, which is caused by the amyloid plaques, and also the neurofibrillary tangles in the patient's brains. So currently, there are some existing AD drugs, but they all have their own drawbacks. 5 of them have been approved by FDA, but they are traditional drugs that only provide symptomatic relief, and their effects will gradually wear off after a few years. There are 2 recently approved new AD drugs, including the lecanemab and donanemab, which targets those individuals with the amyloid pathology. So they treat the individuals with mild cognitive impairment or mild AD-related dementia with increased beta amyloid A beta in the brain. However, we still need the new early diagnosis to achieve the early detection, and we also need to have the disease-modifying drugs. And it's important to understand the disease causes as well as identify new drug targets. So I'm here showing the 2 new AD drugs, and it's clear to see that those drugs are targeting the early stage of this disease. For example, for lecanemab, it shows that it targets the patients with the CDR-SB score at around score at 3, which is classified as the MCI patients, and can effectively delay the cognitive decline. Therefore, it's important to have early detection of individuals that can benefit the early intervention and promote the therapeutic effects of AD drugs. However, we still need new diagnostic tools for those early stage of the disease patients. For those early stage patients, they are targeted by those anti-amyloid drugs like lecanemab and donanemab. However, for those patients, the pathological changes, that is A beta depositions, occur in the brains of the patients 10 to 20 years before the real onset of clinical symptoms. And patients often go to the hospital to have the clinical consultation when they have already severe memory loss. And at that stage, they already have the intermediate or late stage of the disease that has been diagnosed too late, and they miss the golden window for the treatment. It's important to have the biomarker-based analysis for those diagnoses. Like here, you can see that the clinical assessment, for example, by cognitive assessment like MoCA score, they cannot really diagnose the disease at early stage when they have no obvious symptoms. Here is an example. For those A beta negative MCI and A beta positive MCI, the MoCA score cannot distinguish those individuals. In comparison, the biomarker-based tests, for example, like brain amyloid PET imaging or CSF measurement, they can distinguish those A beta positive MCI individuals versus negative MCI. However, those methods are very expensive or invasive, that they cannot be largely for population scale screening. Therefore, it's important to have a simple, convenient, and accessible biomarker test for populational scale screening of the early stage of the disease. And blood-based biomarkers is an ideal solution. And particularly, there are already some brain pathological proteins, such as the p-tau217, that are significantly altered in AD blood. Nonetheless, we still need more blood-based biomarkers to better capture the disease status, such as the inflammation or vascular dysfunctions that still lack of biomarkers to really assess the disease status. And in order to achieve an accurate, early, and comprehensive evaluation of AD status, we need to develop new blood-based biomarkers and assays for AD. And that comes to our lab's research focus. So we would like to develop new blood-based biomarker assays to achieve early detection of the disease and the amyloid pathology. We would like to develop a blood test that is beyond the existing biomarker assays, including the brain imaging and CSF test, the detection of brain pathological hallmarks, like in the blood, like ATN. And then we conducted the first large-scale and comprehensive blood protein screening in AD patients that we measure the biomarkers in multiple biological processes, including the AD pathology, the inflammation, the vascular functions, the innate immunity, the metabolic dysfunctions, all those pathways biomarkers, and then to develop a multi-protein blood-based test. And we show that it can accurately detect AD with accuracy above 96% and detect MCI with accuracy above 87%. And it can well correlate with brain amyloid pathology. So in details, we first conducted a large-scale screening of blood protein biomarkers for AD. It is the first comprehensive screening of blood proteins. We collected the blood samples from healthy people as well as AD patients, and we utilized the Olink target protein detection technology to measure the levels of more than 1,000 blood protein levels in every individual. We conducted the big data analysis to identify those candidate proteins that can represent the blood protein signature in AD. Our data show that there are novel AD blood biomarkers in multiple biological pathways. We then performed the co-regulation and network analysis to identify different protein clusters in AD plasma. And we show that for each protein cluster, it is associated with distinct biological processes and unique cell type expression profile. For example, cluster 1 is majorly expressed by endothelial cells, and the cluster 7 is majorly expressed by neurons or oligodendrocytes that mainly come from the brain. So this data show that we have captured a broader spectrum of biological processes related to AD, and it may reveal potential new pathological mechanisms. Thus, it enables a more comprehensive evaluation of AD status that may help to achieve the early screening and staging of the disease. Based on this finding, we developed a multi-protein blood test for AD. So we leveraged the Olink focus panel and to detect the levels of 21 candidate blood-based biomarkers that's related to multiple biological pathways, including the neurological pathways, the cardiovascular, the metabolic, the immune, and cell regulation pathways. And then we also developed an in-house algorithm to calculate AD risk scores based on the levels of these 21 blood proteins to achieve an accurate classification of AD-MCI. We validated this biomarker assay in 3 independent cohorts across ethnic groups, including a Hong Kong Chinese cohort that has clinical diagnosis, and another Hong Kong Chinese cohort that has further A-beta pathology examination by the amyloid PET, and the Spanish cohort that has the CSF A-beta measurement. And we show that this blood-based biomarker assay can achieve consistently high accuracy in all those 3 independent cohorts. Moreover, we show that the score developed by our algorithm is positively associated with the brain A beta pathology, which can indicate the disease progression. So those data clearly demonstrate our assay can not only used for the early detection of the disease, but also to indicate the progression of brain pathology across different ethnic groups. So here is the detailed data of our testing in different cohorts. You can clearly see that the 21 protein panel can well distinguish those patients with MCI and patients with AD from those cognitive normal individuals. And such fold change actually is larger than the traditional biomarkers, including the plasma A beta 40 to 42 to 40 ratio, the NFL, as well as p-tau 181, especially at the early stage of the disease, such as the MCI. And this actually has been consistently validated in the European descent cohort. You can see that the A beta positive MCI and A beta positive AD, they have very high scores versus the A beta negative cognitive normal individuals. And we also validated this in the independent amyloid PET defined Hong Kong Chinese cohort. It can well distinguish the A beta positive patients versus the A beta negative healthy control, as well as A beta negative MCI individuals. Moreover, we show that there's a significant positive correlation between the AD risk score developed by our 21 protein panel versus the amyloid PET status. This data together demonstrate that it can achieve accurate detection of the A beta positive MCI and AD, and it can indicate the A beta pathology in the brain, which can help screen patients for treatment and monitor the drug effects. And this is the data in our validation in the Spanish cohort. You can see that the consistent high accuracy to distinguish the A beta positive AD versus A beta negative cognitive normal individuals, and also detect the A beta positive MCI versus A beta negative cognitive normal individuals. And there's a negative correlation between the CSF A beta ratio versus our AD risk scores. So together suggesting that our assay can indicate the disease progression. Moreover, since our biomarker assay measures 21 blood proteins from different biological processes, we also can utilize this assay to achieve the multi-dimensional analysis of AD status. So here on the right panel, you can see that this is the individual's AD status evaluated by our assay. It can simultaneously evaluate the neurodegeneration, the inflammation, the vascular activities, the innate immunity, and the metabolic activities of that individual. Therefore, it can simultaneously evaluate multiple biological processes that are involved in AD to achieve the multidimensional and comprehensive analysis of AD status. As I mentioned earlier, the early detection of the disease is essential for the early treatment and management of the disease. Therefore, we are now currently developing further biomarkers for the early stage of the disease that's specifically for MCI and early AD. And we are collaborating with clinicians in Hong Kong to collect the blood samples from more than 380 individuals that are either healthy or MCI patients or early AD patients or AD patients. We are using the same Olink technology to measure the levels of those 1,160 blood protein levels in every individual, and then conducted the big data analysis to identify the candidate blood proteins that are associated with AD and MCI. Our preliminary data show that there are novel MCI and AD associated blood proteins. There are more than close to 500 plasma proteins that have significantly dysregulation in the MCI blood. We also compare this data with our previously published AD-associated blood proteins, and we show that there's a very strong positive correlation with the dysregulation of those proteins in AD-MCI. And in general, those proteins actually have stronger dysregulation in AD than the MCI, suggesting that the dysregulation of blood protein actually is associated with the disease progression. And the interesting finding is that when we further look into those MC and AD associated proteins, we find that those proteins actually are involved in different biological pathways with distinct dysregulating patterns. For example, some proteins have similar dysregulations in MC and AD, and therefore they suggest that they are involved at the early stage of the disease. So we call them as early dysregulating proteins. And those proteins are related to the downregulation of innate immune response as well as the upregulation of angiogenesis. There are also some proteins that are positively associated with the disease progression, meaning that there are stronger dysregulations in AD than MCI. Therefore, these proteins can be utilized to indicate the progression of the disease. So we call them progression indicating proteins. And they are involved in cell adhesion and protein ubiquitination. Also, there are group 3 proteins that they only dysregulated in AD but not in MCI, suggesting that they are involved at the later stage of the disease, and we call them AD stage proteins. And these proteins are related to inflammatory response as well as chemokines and cytokines. This data together provides candidate blood proteins that can be utilized for the early classification and staging of AD-MCI. And it also provides insights on the pathophysiological mechanism of the disease at different stages. So similarly, we utilize the co-regulation analysis to identify the protein clusters, and we show that there are 18 protein clusters that can be utilized to indicate the dysregulation of those different groups of proteins. And therefore, we also select a hub protein to indicate the activity of different protein cluster, and together there are 18 hub proteins. We then utilize those 18 hub proteins to develop a second generation of blood test for detection of A-beta positive MCI and AD. It can achieve earlier and more accurate detection of MCI with accuracy of above 90%, as well as accurate detection of AD. Also, it can better differentiate and indicate the brain amyloid pathology in those A-beta positive MCI and AD. So here is the preliminary data in 2 independent cohorts, and you can clearly see that the second generation of the panel actually can well distinguish the A-beta positive MCI and AD versus the A-beta negative cognitive normal and A-beta negative MCI individuals. Moreover, there's a very good distinguishment between the A-beta negative non-AD dementia versus those A-beta positive AD patients. And in general, the accuracy is above 90% for detecting A-beta positive MCI. And for detecting the overall A-beta positive pathology, the accuracy is about 88%. There's also another interesting finding that based on those 18 proteins, we can develop the multi-scale scoring system to assess the activities of 5 AD-associated biological processes, including the neurodegeneration, the inflammation, the innate immune, vascular dysfunction, and metabolic dysfunction. And when we examine those 5 biological processes in the different groups of individuals, including the A-beta negative cognitive normal, the A-beta negative MCI, A-beta positive MCI, A-beta positive AD, and A-beta negative non-AD dementia, we show that those 5 biological processes actually have distinct dysregulating patterns. For example, for the number 3, which is innate immunity, they only have dysregulations in A-beta positive individuals, but not in A-beta negative MCI or A-beta negative non-AD dementia. This can be explained by the microglia activities, because microglia responds to the A-beta that is specific to those A-beta individuals. In comparison, for the number 4, which is vascular functions, you can see that the 4 groups of people all have significant dysregulations. And in particular, the A-beta negative non-AD dementia has most severe dysregulation of vascular functions. And this is also consistent with previous findings that the A beta positive individuals will have vascular dysfunctions, and for those A beta negative non-AD dementia, a majority of them are actually due to the vascular dementia, which therefore they have the most severe vascular issues. Taken together, this data demonstrates that our blood-based biomarker assay can possibly reveal the distinct pathological mechanisms among those MCI, AD, and non-AD dementia, and it can enable the multi-scale assessment of AD status. Taken together, we have developed the first comprehensive blood test for early AD and MCI. It can facilitate the use of AD drugs such as lecanemab and donanemab for AD treatment. It can help identify the patients at early stage for drug treatment, and it can also to evaluate the treatment response and the efficacy for disease monitoring. More importantly, this biomarker assay can achieve the multidimensional assessment of an individual's AD status, and this actually is the key to achieve the development of personalized medicine. And we have licensed this technology to a startup company in Hong Kong that can provide now the AD blood test service to the public. Lastly, I would like to thank the Professor Nancy Yip's research team, particularly Professor Nancy Yip, Professor Amy Fu, Dr. Fanny Yip, and Dr. Joyce Ouyang, and all my team members. And I would also like to thank our collaborators and the hospitals. And as well, lastly, we would like to thank all the funding support. And thank you for listening.